injections of Avastin, same day. And both injections had been drawn from a bottle. So note that the things I'm highlighting, because those will bear on importance as we talk about safety down the road. So a few days after this, she was referred to us with left eye endophthalmitis, or let me say signs and symptoms of what was obviously endophthalmitis: pain, redness, hypopyon, and vitreous opacity. And we did all we could to rescue that eye. Luckily, it was only in the left eye. You know, to use the word lucky and endophthalmitis is rare, but this patient had gotten bilateral injections. Somehow the right eye was fine, but the left eye suffered endophthalmitis. So we gave intravitreal antibiotics. None of it worked. We did vitrectomy twice. It did not work. And eventually she's currently NPL in that eye, and the eye is actually undergoing phthisis. The right eye, after that incidence of endophthalmitis, were unwilling to continue on Avastin, converted her to Lucentis, and she has done well. That eye is currently 6'9". So that is the story we shall start with, to tell you that these complications of intravitreal injections are real. So why the topic? That is why we are discussing this topic. And then we shall talk about the preparation, safety, storage, and administration, because those are the points at which you must be extremely cautious to ensure that you are administering safe injections. It's not just at the point of sticking that needle into the eye. It's from the point of receiving that drug from the supplier. So we are discussing this topic because we are having increased injection burden. So the global population is going up. You know, it's the total number of diabetics, as you can see there, is also going up exponentially in Africa, India, and the rest of the world. Then, of course, our diagnostic capability is also increasing. So we are finding more and more indications for these injections at earlier stages. And then also the indications for these injections are increasing. Previously, it was AMD, then diabetic macular edema, then vascular occlusions, then retinopathy of prematurity, then proliferative diabetic retinopathy, then Eales disease. It's like you can use anti-VEGF for everything. Even pterygiums now are indicated for anti-VEGFs. So injections are increasingly being used as we find more and more indications for them. Now, this injection burden, as you can see, is becoming too heavy for the ophthalmologist. And in certain settings, this role is being distributed to other cadres within the healthcare, especially the eye care fraternity. And this could be anywhere from nurses to optometrists, ophthalmic clinical officers. Now, intravitreal injections are intraocular surgery. That's the one thing you must remember. So, sorry, let me put my phone on silent. Yeah, so intravitreal injections are intraocular surgery, and the complications are real. So let's look at the preparation. The safest preparation of injections is no preparation at all. And by that, I mean getting drugs that don't require you to fractionate. So we are talking about single dose injections, pre-filled syringes, and preloaded implants. Then you go to aliquoting and repeat withdrawal. So for the single dose drugs in a vial, we have Patisiran locally, which is ranibizumab. We also have Lucentis, which in our setting is being phased out by Patisiran, and of course Eylea. These are single dose drugs in a single vial, and these have traditionally been safer because you have a single vial, draw from it, discard along with everything else. So these have been the safest options. An even safer option is what we are now getting in form of pre-filled syringes. So you don't even have to draw from the vial, because drawing from the vial of portion. So now we are having filled syringes of both Lucentis and Eylea being available in the market. We also have preloaded implants. For those who see Osidex implants being given, we have Osidex, which is a dexamethasone implant. This is preloaded, so you just get it out of the bag and stick it into the eye. So these are safe options with traditionally lower levels of complications as far as infection is concerned. Now, this is where the business is, because the given anti-VEGF injection is still bevacizumab, whether it's from Roche or other brands of bevacizumab, which are now being produced even by other pharmaceutical companies. Now, aliquoting is next preferred. So you can prepare several injections from one vial. Some people actually separate from one vial into separate small single-use vials. So people are doing different things in different parts of the world. And then also intravitreal triamcinolone, because it will come in a vial, and many times you can get 2 doses from a single vial. So it are being shared out. So these pose risks for infection. So when it comes to early quoting or fractionating this, farm your source. Make sure you're getting legitimate Avastin or whatever brand you're using from registered distributor in your country. Then prepare these things in a sterile theater with gown, mask, and gloves. That is a requirement, especially if you're the primary person preparing. Your assistant still has to have a mask and a cap and gloves, be gowned, but you as a person preparing must prepare in those settings for safest delivery. Then it is advised that you specimen from each vial and send for microscopy, culture, and sensitivity, so that before you disburse of that batch, you've at least waited 2 days. So many times they'll advise you can take the first and the last, or just any 2 randomly. And when you prepare this way, it is safe ideally for 3 months. Many people use the expiry date on the drug, but once you fractionated, things change because of that risk of contamination. And therefore, it is generally advised, if you're using the standard plastic syringes that we use, you can keep that for up to 3 months. And of course, this is double bagged in sterile pouches. If you're keeping it in glass syringes, it's good for even up to even 21 months. And depending on the type of plastic syringe, you could extend it even up to 9 months. But generally, keep it as a rule of thumb. You don't want to keep it for more than 3 months. Now, what a lot of centers still do is where you draw from a single vial and return it into the fridge, draw when the next patient comes. Now, if you're drawing from a single vial, ideally you should not keep it for more than 1 week. Studies have shown that beyond 1 week, you're risking infection, and because of repeated injections, you're pushing plastic into the Avastin, and therefore you start getting contamination with rubber from the cap, and you start getting forms of uveitis that you can't quite explain. It has been advised you can push it for up to 2 weeks. So definitely do not pass the 2-week mark. Yeah. So now when it comes to storage, so that is now you have received it, now you need to store it. One, ensure the cold chain has been maintained. As it comes, look at the documents. Store in an exclusive and lockable refrigerator. Please note the word exclusive and lockable. The exclusives, make sure you're not storing all these other items we are seeing here. You know, you might be keeping stuff, bread for tea time in that same fridge. You're keeping milk, your lunches. The fridge that you're keeping your intravitreal drugs should be just for drugs and nothing else. It doesn't have to be Avastin only, but it should ideally be for drugs only. And then it should have maintain a temperature of 2 to 8. And how do you ensure that? That it has a temperature display, a power backup, and a temperature log. Because you might be looking at it and it's telling you 2 degrees, but there was a power blackout last night because you don't have power backup. You have no temperature log to tell that temperature, it was at room temperature for most of the night. You do not know. So a temperature log is important. So that comes to storage, because if you're not storing in ideal conditions, you have an increased risk of contamination and loss of effectiveness. So you might just actually be, injecting patients with useless drugs because of poor temperature control and wondering and blaming Avastin for not working. Okay. Now, the administration before you give the injection. Again, from your fridge to your injection site, keep it in a cooler box. If the fridge is not in the theater, of course, because for some people, there are different sites. So to take it to the injection site, whether it's a theater or a clean room, put it in a cooler box to maintain the cold chain till the point of administration. Systemic assessment, of course, for the patient, check the BP, check the sugars, make sure they are fine. Confirm no evidence of local infection. Inspect those eyelids, at least in the conjunctival phonics. You don't want to be giving injections in patients with conjunctivitis and styes. Then confirm the eye, because part of safety is ensuring you're giving the right injection into the right eye. So you confirm the type of injection the patient is anticipating and the eye to be injected so that you're sure it's the one, and then confirm the same from the file. And if there's any discrepancy, ensure you clear it out with the doctor who saw the patient and the counselor and the patient. Then you've confirmed, sorry, that's a repetition. Then mark the eye clearly, whether it's a sticker, a wristband, whatever you mark with, make sure it is marked clearly so that you do not administer to the wrong eye. Then administer adequate anesthesia. Proparacaine is ideal, but whatever you have, paracaine, methocaine, they all work. Proparacaine is good because it acts fast and has minimal side effects and minimum toxicity to the epithelium. And then you can also use your lignocaine gel together with drops or even by itself. Both are effective. Now, safe administration. Now, this is the hot spot where you're actually giving the injection and you need to follow the steps as prescribed. So first thing you'll do is after now the patient is on the chair, you've checked all those other things. So first you'll ensure the conjunctival phonics is, so to speak, as close to sterile as possible. And we use povidone for this. Some people use antibiotics for 3 days prior to injection. Some people flash betadine into the eye. You don't need to do that. You just need drops. So put the drops after you've adequately anesthetized, because povidone drops sting quite severely. There's preparations of 1% povidone up to 5%, whichever is fine, but the recommended is actually 5% povidone. So put a drop of 5% povidone and do that before you start preparing everything else, before you start taking out calipers and things, so that it sits in the phonics long enough to have an effect. Because if you just put the drop and inject, it might not have killed the bacteria adequately. So put the drop, then start preparing your tray, putting your things in order, so that as you're doing that, the povidone is having effect to clean out your conjunctival sac. Then you clean your skin and lashes, and for this 10% povidone iodine is advised. You can use cotton buds or gauze or whatever you have available. So put it in, and then once you put that, continue with preparing your set, because also the skin needs time for the povidone to dry and therefore have its maximal effect. Then eventually you put your speculum. I prefer to use a speculum. Not everyone uses it. If your patient is cooperative, you don't have to use a speculum. View it as an extra point of contamination. But of course, we're using a sterile speculum that has come with a Avastin set. So put your speculum in and then get ready for the injection. Then you can put your final drop of povidone over the injection site just prior to giving your intravitreal injection, whichever one it is. Then mark your site, of course, with calipers. You can use the adjustable ones or the fixed ones. 3.5 ideally if the patient is pseudophakic, or aphakic, 4 millimeters aphakic. Then what I always advise is that you displace the conjunctiva with a cotton bud over the sclera, so that the point of perforating through your conjunctiva and the sclera are displaced from one another, so that after the injection, the conjunctiva covers the sclerostomy where the injection has gone through. And that just offers an extra point of protection against infection. Then avoid conjunctival vessels. Now, I've had many patients coming in with subconj hemorrhages, and for the patient, it's a matter of panic. The eye is so red, they think this bleeding is inside the eye. Us as ophthalmologists, it's a subconjunctival hemorrhage because of the injection, and will clear away without any adverse effects. But for the patient, it really bugs them. So before you inject, make sure you're injecting at a site that does not have blood vessels, just for the patient's peace of mind. All right. Then inject, and I've highlighted slowly. Many times we're in a hurry, you have 5-10 patients for injections. Give injections slowly, because you don't want to disturb the vitreous too much, shake it around. You might, cause some bleeding. There's things like what you call jet stream retinopathy. You don't want to inject too fast. Give injection slowly. It also doesn't cause the pressure to rise too suddenly and occlude your artery. So inject slowly into the mid vitreous, so that then you're ensuring your patient safety even during the injection. Then, of course, after that, put a drop of povidone. It is not necessary to patch an eye after intravitreal injection. Even Osidex, which is a large gauge needle, once you've done your povidone drop, you do not need to patch the eye. I always say this, and then I see patients coming back with eye patches after injection. You do not need to patch the eye. If the patient is going to a dusty environment and they're afraid of something, they can wear sunglasses. If the patient insists he's entering a matatu and will be jostled and his house is very dusty, you can put it, but tell him to take it off the minute he gets home, because you do not need to patch eyes after intravitreal injections. Now, another very important step is check your visual acuity after the injection. And of course, you must know what the visual acuity was before. Patient could be having a vitreous hemorrhage and his hand movement. You will not expect it to be counting fingers after the injection. So know what the visual acuity is before, so that you know what you're assessing for. Even just checking if its perception of light is adequate enough, considering, or counting fingers. So for most patients, I'll check counting fingers. For patients with very poor vision, I'll at least check for perception of light. And this is because of the risk of sudden increases in intraocular pressure, which cause sometimes, you'll notice optic disc pulsations, the retinal vessels pulsating, or actually a central retinal artery occlusion, and the patient cannot see. And you need to identify this immediately after injection, so that if the pressure has gone very high and the artery has occluded, you immediately do a paracentesis. And because of checking this, I've done several paracentesis. It actually happens quite often, but you will only know this if you check. So check your visual acuity after injections always. And then advise the patients on danger signs, because it's good for me and you. We know the signs of endophthalmitis, but the patient doesn't. So you just tell the patient, if your vision drops, eye becomes red and painful, please call me or come back immediately. You must give them that information so that if a problem, come back real fast. Then, of course, we are now doing injections in retinopathy of prematurity. This intervention is, potentially life-changing if you save one child from blindness from ROP. But if you cause endophthalmitis, you really have done nothing. So you must ensure all precautions are followed for ROP injections. On top of that, swaddle your baby nice and tight, as you can see there, so that you have minimal movements. Injection site is usually about 1.5 millimeters from the limbus, and you go vertically down. Remember, these babies have a relatively large lens compared to the size of the eyeball. So you need to make sure that you're staying clear of that lens. Otherwise, you now cause a cataract. So the advanced events and their management, these are many. So of course, pain, just adequately anesthetize your patient. And sometimes however much drops you put, the patient still feels some pain. But make sure you have put adequate drops, given the patient enough time for the anesthesia to take effect. And a good way to know if it has done that is when you put the povidone drop, the patient should not feel itchy or painful. Subconjunctival hemorrhage, as you can see there, and you can see it looks alarming, but you always just observe and reassure the patient. It often resolves spontaneously. Raised intraocular pressure, this also occurs quite often, and it might be due to just the pressure, caused by the injection volume. There's a time we used to inject 0.1 of the anti-VEGFs or steroids, but I mean, for now we do a standard 0.05 mLs, and therefore you don't get that huge rise in pressure. But even with that, you'll still have pressures going up, sometimes 40, even 60 millimeters of mercury. Some patients are steroid responders and will get raised intraocular pressure for patients where you give steroids. And sometimes some anti-VEGFs will give some idiosyncratic reaction and cause very high pressures in the eye that you can't quite explain. So you need to watch out for those. I know in training institutions, they'll always check pressure on day 1, week 1, month 1. And you can justify it. Some places will check, especially for steroids, at least at week 2 to 3, because that is when you expect the pressures to go up. And if you record high pressures or visual acuity that is low following injection, do a paracentesis. For patients who develop the kind of steroid response glaucoma, of course, put them on anti-glaucoma medications, which you later try to taper off after the steroid effect has worn out, but some of them still require them, and some of them actually go on to require glaucoma surgery. Another common side effect is floaters, and a lot of your patients will complain of this. Now, floaters can be of different things. You can see in the first image there, a patient got an intravitreal injection of Ozurdex, but you can see this thing was injected mid-cavity and is actually just hovering behind the lens. You can imagine patients report that they see wipers like of a car because that thing keeps dancing around. So for this, always inject inferiorly. Never give Ozurdex superotemporal quadrant. Always go inferotemporal, inject it inferior and anterior so that it sits somewhere over the pars plana. And that way, you get it, the patient doesn't get disturbed so much by that really irritating floater. Ozurdex has also been known to migrate, especially patients with peripheral iridectomies or zonular issues. You can actually find that Ozurdex implant in the anterior chamber. So, and of course, it causes a lot of irritation to your corneal endothelia. Other floaters is bubbles. You can see these 2 little bubbles here. Make sure you flick your needle and make sure you get out all those bubbles. Because even just last week, I got a very, very senior civil servant who got intravitreal injection given, and now he calls me because he knows me, and he's reporting these bubbles floating around. And it was just this. If you don't flick out the bubbles from your syringe, the patient will appreciate them for sometimes from maybe 2 to 5 days, depending on how much air you injected into that eye. So get those bubbles out. They will disturb you. The patients will even come at night, and you're called to a hospital at night because the patient has floaters following intravitreal injection, and it's just an air bubble. And you have come from another county in the middle of the night, risking life and limb, just to find that it is just a bubble in the eye. So get those bubbles out, avoid these side effects. Then, of course, triamcinolone. That's another one because it's a solution and it's cloudy. So same thing for triamcinolone. Never give superotemporal, especially in vitrectomized eyes, because it now just floats and scatters all over into that eye. So triamcinolone, again, always inferior. Keep that injection down there and sit up your patient immediately after the injection so that the DAWA, the triamcinolone settles inferiorly, and therefore the patient has less of those floaters. This was a patient we also saw. We had two similar patients who came with lens track cataracts. Patient who had very good vision, but a week after the intravitreal injection, vision was gone. And you could see this cataract had formed, and you can see a track where the needle went through that lens. So this one always is about technique. Make sure you're injecting for that mid-vitreous cavity. Don't give it horizontally like you're doing cataract surgery to avoid injuring that lens. This is a common side effect. We have seen several. A couple coming from training institutions, especially where people are still learning how to give injections. So avoid the lens, of course, at all costs. Or sometimes it's the patient. There's one patient we had who moved his head. During injection, he suddenly shook his head and needle hit actually his lens. So make sure you document such events if it happens to you during surgery, that patient moved, so that if such a cataract happens, we are sure why it happened. So if you get such a cataract, of course, you can do 6 small incision cataract surgery and IOL because you've perforated that capsule. And therefore, phaco is a bit risky because, phaco causes your eye pressures to go up. So you can get actually lens dislocation into the vitreous cavity when attempting phaco in patients who've had traumatic cataracts caused by intravitreal injections. So if it is not a cataract that develops too quickly or not that doesn't require urgent surgery, you can do a phaco, but give it at least a month for some fibrosis to happen on that capsule. And during your surgery, manage your fluidics very well, lower your bottle height, do not do hydrodissection. Do hydrodelineation, avoid hydrodissection, because that tends to cause the capsule to rupture and your nucleus drops into your vitreous. Avoid nuclear rotation, which we do a lot of during phaco, and use a dispersive visco as opposed to your very heavy cohesive visco. Those are some of the tricks you can use to do a safe phaco in a patient who's gotten a cataract following intravitreal injection. Then we all know of TAS, toxic anterior segment syndrome. Now, we as the posterior segment people have come up with toxic posterior segment syndrome. And personally, we have seen these after injections of triamcinolone. It was the hugest culprit for this, just because sterile endophthalmitis and bevacizumab. And you get a sudden loss of vision, and usually it's on the same day. Patient will call you that evening, and that helps you at least rule out endophthalmitis. But when you see it, it looks a lot like endophthalmitis. You'll have some fibrin in the AC in the posterior segment, lots of cells, but it happens so quickly, often the same day as the injection. So you get severe intraocular inflammation, primarily in the vitreous. There's not much redness or pain as you'd expect in endophthalmitis. So it looks like a painless endophthalmitis. And of course, that is your number one differential. And so the ones we have seen, we have treated with frequent topical steroids, intraocular steroids, of course, in a case where it was not caused by the steroid. And in one case, we even had to do a vitrectomy because it was getting towards the weekend and the inflammation is not settling and you're not sure what you will find when you come on Monday. So one case, we actually had to do a vitrectomy and patient did well. So what else can you get? Vitreous hemorrhage, of course, is a side effect that you're warned of. And this, of course, is from poor technique where you either go through the ciliary body or the retina, or patients on anticoagulants have been seen to get that. And patients with PCV, polypoidal choroidal vasculopathy, which is a subform of age-related macular degeneration. Sometimes they get that fluctuation in pressure causing some kind of breakthrough bleeding. and also a PVD. If you induce a PVD injection, this will happen with bigger injections like Ozurdex. You could get vitreous hemorrhage. So of course, do your right technique and observe any spontaneous, for spontaneous resolution. Often it does. If it fails to clear, especially, I mean, for this one, you'll give it maybe a week or two. If it's not cleared within 2 weeks, you might do an earlier vitrectomy because you're not sure what has been injured. Because if there's a hole through the retina, it's going to detach soon. So of course, retinol breaks, like in this case, you can see a patient got a retinol break following intravitreal injection right there. So this was seen early and laser was done in that area to kind of avoid retinal detachment. So that's a barrage laser. And in this case, you can see retinal detachment happened and patient had to have a vitrectomy. And there's a high incidence of failure of these vitrectomies. They often require more than one surgeries because for some reason they get a lot of proliferative vitreoretinopathy. Then, of course, the mother and the father, the guka and the shosho of them all is endophthalmitis. And you must do everything within your power to avoid endophthalmitis. So this is safety at all levels, patient counseling, bilateral injections on the same day. I'll just advise you, I'll not say don't do it, but if it's especially an early quoted drug, think hard about it. Think really if the patient cannot go and come back, another day, a week later. If you must do it, do a double setup. Take each eye as a separate patient. Use different gloves, different set, different everything, even Avastin, if you're using Avastin or intravitreal or any other injection, whether it's Lucentis, get from or Patisiran from different batches so that you're not risking a bilateral endophthalmitis, because bilateral endophthalmitis would be a disaster. All right. So of course, if you see a patient with signs and symptoms of endophthalmitis, high index of suspension, go for it. Treat aggressively intraocular or intravitreal antibiotics, early vitrectomy before your cornea goes hazy. If you can have a chance to do a vitrectomy, get all that gunk out of that eye. So in summary, we are here to ensure injection safety at all levels. You have figured by now that giving intravitreal injections is more than getting that needle and sticking it into the eye. Really, if you think about it, it is a very simple procedure. Removing a chalazion is more complicated than giving an intravitreal injection. Yeah, so it is a simple procedure, but it is intraocular surgery, and therefore you must ensure safety at all levels. Counsel the patient on danger signs so that if they start developing signs of endophthalmitis, they come back to you as soon as possible. And then if, worst case scenario, you get some of these complications, have a clear referral network in place so that you know who you'll send them to and quickly for rapid management. So thank you. And we shall be, entertaining questions at this point. I'm happy my moderator is Oscar Onyango. He is at liberty to answer as many questions as he likes.
Thank you, Muchai. Thank you very much, Muchai. That was very eye-opening. It's good to hear things over and over so that they sink, Probably I have a comment and a question. The comment is regarding there's a meta-analysis, I think on endophthalmitis that talked about the gel being linked with endophthalmitis cases. I don't know if you came across that in any of your readings. The use of xylocaine gel, I think, having more cases of endophthalmitis than the normal drop, which are paparacane, etc. Yeah. Then the second thing is a question. What's your take on sending a patient home? You inject today, then you tell the patient come back tomorrow for review to make sure everything is well, because that is done in some centers, So the patient is injected today, goes home, comes back the next day for review, and is charged afresh. What's your take on that one?
Well, it's definitely lucrative if you're charging afresh. I don't do that. I know in training institutions, like I know in Kenyatta, that was the protocol. Patient would have to come first day. But you see, this a point at which you're getting injections given by trainees. So you really don't know what happened at that point, and you really want to see that eye the next day. But I mean, in centers where your injections are being given by, for day one is pressure. But the highest spike in pressure is actually immediately you give that injection. That is your highest pressure. And that is why I spend more effort on that. I check the vision in patients who have let's say I was doing a PRP that I had blocked and also required an injection. Once I inject, I also do an indirect fundoscopy so that I see any pulsations or blocked central retinal artery. And if I see that, I'll do a paracentesis and I look again. I will not discharge the patient with poor retinal blood flow. So I either check the vision or I do a fundoscopy. That way I am sure that this pressure, in as much as it will be high at that point, it's not dangerously high or debilitatingly high. So by day one, your pressure is much lower than what you had at that point. So even if you're checking pressure, you already confirmed that it was not a dangerous pressure. So the point at which you need to see them for steroids, I always say 2 to 3 weeks. That's when you expect a spike. Otherwise, counsel your patient properly so that if they're getting any complications, floaters from vitreous hemorrhage or whatever, or endophthalmitis, worst case scenario, they know how to pick out the symptoms and come back quickly.
Sorry, thank you so much, Muchai. Agnes, Kalu, anything you wanted to add?
No, I do not have any questions, but if anyone has, they could post them on the chat and then we discuss them.
Let's wait for those questions. I recall you once got an Avastin bile sample, no, quite like 8-9 years ago or something, and we stored it at -20 degrees in the theater fridge, and we used to prepare and we give. I can say I think Dr. Nyaga is part of the group. He knows what I'm saying. And I think at one point we gave that thing for months. At one point, I'm not sure if it was me or Dr. Nyaga ended up with a very crazy uveitis in a patient, and it taught us a lesson about this thing of repeat single vial, pulling in, pulling out, pulling in, pushing out. Yeah, and we never did that again. We discarded everything that was not fridge after that, -20. You're muted, Gachago.
Yeah, definitely freezing is not a great idea. Yeah. Okay, good.
Yeah, we learned that on the hard way. I think at this point, I'm not saying.
There's
a question there. Kalu, you can say that?
Yeah, there's a question here. Is it recommended to do intravitreal injections in the outpatient clinic setting?
I'll give my take and then maybe Oscar can also comment. I mean, when we started off intravitreal injections, you had to take them to theater, gown, mask, everything. And it was, but with time, US, Canada have led the way in, reducing the myths around intravitreal injections. And these days, injections are being given actually even at the slit lamp for, extreme cases where you look at the patient on the slit lamp, put the povidone while the patient is still there, put the, anesthetic and inject the patient there. And then even without a speculum, you just tell the patient to look up and inject it, So you can now give intravitreal injections in the outpatient setup. I have not been as aggressive as to take it to the slit lamp because, this is also Africa. You don't want to risk bugs that might be hovering around. People have come from villages, you're dealing with farmers. A guy could just have picked a few ngwashes from the farm and come there. So you're not sure about the state of hygiene even at that point, yeah? So we now, at least at CTI, we do it in the outpatient department. We have a room that we've separated for that. So it's not theater, it's not a sterile room, but it's a clean room that we use for injections. And of course, we'll wear sterile gloves and you'll mask and avoid talking. And of course, we'll drape the patient and do all those other nice things I have described. So you can safely give them in the outpatient department. But remember that safety is more than just about the point of delivering that injection. We have ensured safety from the point at which we receive the drug up until the point we discharge the patient.
I think that's very well said. I agree very much, Dr. Gachago. The issue is it doesn't have to be a theater setup in terms of sterility, and because the places where people still gown everything, that's really expensive for the patient. Makes the injection a very, very expensive affair. And most of the injections we're giving, you're looking at giving between 7 probably to 10 injections in a year. So you can imagine the cost of that each time you're doing that. So it's an appropriate room, a procedure room, as you can call it, and you mask and no talk. You know, the other study talked about the oropharyngeal bags that float in the air that end up giving you endophthalmitis. So the less people in the room, incidentally, you don't want a crowd, and then masking and of course sterile gloves. If you have to do more patients, of course, you're changing gloves in between, etc. But yes, it can be done in the outpatient setting in a clean room. Yeah, I agree completely. Any other comments?
Please allow me to ask my question verbally. I can't chat because I'm driving. I wanted to get the take of Dr. Gachago and Dr. Oscar on the practice of aliquoting Avastin and then packing it in paper bags with ice packs and sending it to ophthalmologists outside Nairobi to do their Avastin injections. Because Dr. Muchai had talked about the strict maintenance of temperature and the temperature controls. So what's your take on that? Thank you.
Muchai?
Well, there's many reasons I am not a big fan of that. Because I mean, once you prepared your Avastin, it's in. I mean,
Yeah,
you've
but
kept it in
Mark
the
is
fridge.
going. I don't know whether he'll accept.
Sorry. Okay.
Okay,
So
I'm okay now.
mute, please.
Oh,
I hope the video is off.
Dr. Jambi,
Yeah, she's
thank
muted
you.
now. Yeah.
Great, yeah. So, because you see, for many reasons. One, because you've prepared you've double bagged your Avastin, of course. But once you put it in an ice pack, one, you're not sure how you get to its destination. Will the temperature of 2 to 8 degrees be maintained for that entire duration? You're not sure. When we're in the hospital, we are basically bringing it from the fridge to downstairs, and we don't bring all of them for the day. We just bring them in small batches, 5 to 10, inject, and as they go. Now, as you transport, another thing that has been seen with transport of Avastin in aliquoted syringes is that there's a higher incidence of inflammation, uveitis, because remember your syringes are plungeable. They glide because the syringe is coated with silicone. Now, as you transport, there's a lot of shaking, and silicone is dispersed from the syringe, bore into the Avastin itself. So you find that now you're actually injecting silicone plus Avastin. And therefore you find patients start getting inflammation that you can't quite explain. And therefore it's not recommended that you transport Avastin over long distances. And you know how rough our roads are. You might end up with more silicone than Avastin in that syringe. So generally, because you see now, if you're transporting other drugs, Lucentis, it's in a glass vial, you'll put it into the syringe when you're ready to inject. So you can transport it that way. But as long as it's in a syringe already, you have risk of silicone getting into the drug, causing uveitis. So I am not a big fan of transporting it over large distances. Preferably, patients should go to a center near them for the injection.
I think thanks a lot, Dr. Muchai, very true. And just to add on to that, many hospitals, I think, decline to give patients the aliquoted form of Avastin because of those very, very answers you talked about. I think what I tell Dr. Intravitreal is just prepare for yourself this thing. Have a dedicated 1 or 2 theater nurses, they mask, they prepare it for you and keep it in the fridge and use it within the stipulated time, 2 to 3 weeks, and you'll be okay. You won't have any of those issues Dr. Gachago has talked about. It's pretty simple to do. Yeah. Dr. Kalu, I think somebody had asked a question down there.
Yes, there's a question about recommending, is it recommended to do routine fundoscopies immediately post intravitreal injection, which I think Dr. Gachago had alluded to during the presentation, with the importance of doing the fundoscopy, especially to check on your retinal artery. So I think we can move to the next question. Nelson asked, after endophthalmitis and prophylactic intravitreal antibiotics have been given, what determines when to do a vitrectomy?
That's a totally different question for this setting. But Gachago, maybe you can say something about that. severity of
Well,
inflammation and indications we can.
yeah. I mean, once you've made your diagnosis of endophthalmitis, you must see your patient every day. So once, I mean, and we're not talking prophylactic antibiotics. This is endophthalmitis, therefore this is treatment antibiotics. You're not giving intraocular antibiotics prophylactically. You're giving them to treat endophthalmitis that you have already diagnosed. So you've confirmed your diagnosis of endophthalmitis. It's not a toxic posterior segment syndrome. So it's endophthalmitis. And at the point of injection, remember, you tap some of it. Whether you can use, if it's very purulent, it comes out easy, so that you've sent something to the lab. And once you inject your antibiotics, you monitor this patient daily. And if at any point you feel this patient is not getting better, some people give a second dose of injection after maybe 2 or 3 days, because you will be doing serial ultrasounds as well if the view is not so great. But as long as you have a clear cornea, see your patient daily, so that the point at which you make a decision to do vitrectomy, you still have a clear cornea. Because once your cornea goes hazy from endophthalmitis, it's a wrap. You're never going to be able to do that vitrectomy. So as long as you're realizing this hypopyon is not dropping, the vitreous activity is not decreasing despite 1 or 2 intraocular antibiotics, go quickly for a vitrectomy. And when you go for that vitrectomy, it's amazing what you find in there. It's like winter in that eye. It's like snow in this eye. There's so much gunk in that vitreous. Really, it's the best thing to do to at least clean out that eye, because it's basically your eye has become an abscess, and you need to get the pus out. So drain that abscess, i.e. do a vitrectomy, and give antibiotics, and ensure that you follow up your patient closely, and you will save a couple of eyes.
Yeah. So it's basically you've done your maximum conservative treatment. You're doing your intravitreal swab every 48, 72 hours. You're doing serial ultrasound. We talked about that even yesterday, I think, with one of the students. Doing ultrasounds can even be twice a day. You're looking at activity, what's going on in that posterior chamber. Okay, that posterior segment, sorry. If there's increased activity, there's visual loss, the pain is persistent, a papillon, you don't wait for the cornea to get hazy, then you send to us to do vitrectomy. You can't do. Though the other side of it is, remember, we're looking at open sky, the eye in the sky kind of vitrectomies that are coming up now. That will happen. But you see, by the time the endothelium of the cornea suffered so much, fine, you'll remove your inflammatory material, infected material, and all. You hope the cornea clears. Maybe it might not. So you don't want to wait for that cornea to get hazy. So we go in earlier at that particular point. But you must have done maximum treatment in terms of conservative. What's your role? What do you think about ciprofloxacin oral in terms of intraocular penetration, Gachago? I still do it sometimes. Some people say you shouldn't. Risk of long tendinitis and stuff like that.
See, when you have endophthalmitis, for me, I say anything goes. If you feel you will sleep better with that thing, because oral cipro has better, ocular penetration than most drugs. I have given it with some level of success. There's one patient I gave, and she had allergy to ciprofloxacin, and she did not know it until that time. So that's when she discovered she had an allergy to it. So there's a downside to it as well. But when you have endophthalmitis, you basically give it all that you have. But the local therapies, of course, is what you'll try hit hard first. Intraocular antibiotics, cycloplegics, and vitrectomy. Yeah,
thanks. Kalu, anything else?
I don't have anything else.
There's a question there by Martin Muhoro.
Okay, I don't
given the high prevalence. Yes, given the high prevalence of diabetic retinopathy and the deficiency of specialists in our country, what's your opinion on the viability of training primary care providers to give intravitreal injections, OCOs to be specific?
Very, very valid question. As long as you can diagnose and you can pick out complications, I'm very much for that. Because remember, Avastin is part of, we call it what? The KEMSA kind of drug. I think it was organized as part of it's in the KEMSA drug list. So it's available at, I believe, all county levels. If you don't have an ophthalmologist, I don't know if there's any county without an ophthalmologist, but if you don't have one and there's an OCO, for example, who does, if you do cataract surgery, honestly, I mean, an intravitreal is child's play, You just do it the correct way and you'll be able to do it very well. So I'm very much for that. But the most important thing, by the time you're doing the procedure, you must know to pick the complication and how to handle the complication. I don't know what your take is, Dr. Muchai.
Yeah. Ditto, I agree. We have trained some clinical officers to give them. They have given them safely over the last couple of years. But as you're saying, you need to have that knowledge and that backup system. In case of complications, they know where to send the patient, preferably within the same institution, so that complications can be dealt with quickly. Yeah.
There's some, okay, Carlos, sorry.
There's another question, Dr. Muchai. Giving an intravitreal injection is a simple procedure and can be done in peripheral centers as well. How often would you recommend VR follow-up for patients given intravitreals in the peripheral centers?
Well, it depends on the indication for the injection. So, I mean, largely, I think in peripheral centers, we are probably talking about diabetic macular edema largely. And I think most ophthalmologists are competent enough to diagnose diabetic macular edema and give the injections. The thing is the follow-up and how it's done, because now in those peripheral centers, do you have an OCT? Because then you need to do the scan to first judge that you're getting improvement on that drug. And when you've reached your endpoint, whatever that is, or whatever that means. So you need to have that diagnostic capacity because there are patients, you will attest that you look at that retina and you can swear it is normal. Then you do your OCT and it shocks you that there's still quite a bit of edema that you thought has resolved. Yeah. So if you diagnose it, if you can get a scan and the patient gets the injections with you locally, you can do your batches, like let's say do your 3 injections, because that's normally how we do it. Do 3 injections, repeat the scan. On your 3rd scan, send the patient for an OCT. Most people are now trained to read OCTs. And if you're getting improvement, you really might not even need that vitreoretinal assessment done. It's in cases where you're treating and you're not getting the kind of response you anticipate. So you're giving an injection, patient's not improving, or patient's getting worse. The patients you give injections and they're getting worse. And in that case, you might need an opinion. Is it drug? Is it the disease that is not responding adequately? Do you need to change your drug? Things like that. So those are the cases where I would say, okay, definitely get a retina opinion. But for pretty straightforward cases where you have capacity to do OCTs and see that there's improvement, then you might not necessarily have to send them actually for a retina review. But for complicated cases, worst case scenario, we always tell them, dilated fundoscopy annually, you can send them to a retina specialist for that.
I agree totally. Yeah, probably OCTs will be at county level very soon, I hope. It's not a very pricey thing for the county. They're giving Calons at much higher price than an OCT machine. Yeah. So.
One thing I have seen is a misdiagnosis leading to, judgment errors, where patients actually get like central retinal vein occlusions and branch vein occlusions. These don't respond as well as you would at diabetic macular edema. So in patients who have central vein occlusions and are diagnosed as, severe, NPDR with DME, as opposed to CRVO with CME, then you're injecting and you wonder why you're not getting the response you hope. So if you're injecting and you're not getting the response you anticipate from a given drug, then it might be worthwhile sending the patient for a second opinion, so that then we are sure we are dealing with the right diagnosis. Because then, like for central vein occlusions, sometimes I just go straight to the better drugs. I'll go straight to Lucentis or to Eylea, and see better results with that. So those are things to maybe get an opinion on sooner than later.
Yeah, thanks a lot. Agnes?
There's a comment from Dr. Mundia. He says he's found it useful to use cyclopentolate to flatten the lens in preterms before injecting the anti-VEGFs. Any experience on this, Oscar?
No, I've not tried that at all. I just inject and I leave the baby happy. I've not tried. No, I'm not.
Yeah.
Muchai?
No, I'm hearing of it today. I'm learning, but I've given several intravitreal injections. I've never done that. It's just the direction in which your needle goes is more important. Yeah. All right.
Agnes?
If I may comment, again, this is Dr. Ndiritu. I'd like to make a comment on the issue of other cadres other than ophthalmologists giving intravitreal injections. I think the example that Dr. Gachago gave, the clinical officers that are giving those injections are doing it in a facility with very close vitreoretinal surgeons. You know, they're in the facility. So, having worked in diaspora for many years, I think it's important that we recognize that not everybody can do a proper fundoscopy, like a full dilated peripheral fundoscopy. So, where you have situations where you have other cadres and they're using a direct ophthalmoscope, a direct ophthalmoscope will miss a lot of pathology that will be picked by an indirect ophthalmoscope. So I think I would differ with Dr. Gachago and Dr. Oscar on that. I think I would leave it to ophthalmologists for now because at least they're trained to do BIO and they would therefore be able to pick up complications quickly. Or if the clinical officers are doing it, then it should be under the supervision of an ophthalmologist who can do a BIO immediately or the next day. Otherwise, then you'll have people who are using direct ophthalmoscopes. They're not able to see the retinal periphery. They'll miss a lot of pathology and we'll lose a lot of eyes. That's just my take. Thank you.
Okay, thanks, Dr. Nderetu. It can be discussed over and over. You see, as long as at the periphery, what's going on at the periphery is covered, and it's someone competent enough to pick up the complications, that's what we're saying. But true, you can't use a direct ophthalmoscope to assess the diabetic retinopathy. That will not work. Or any complications for that matter that arise from that. So it's still open. It's a topic open for discussion. I believe it will be revisited maybe for another year, 2 years. But I do believe at some point we'll have paramedics in East Africa injecting this condition, this anti-VEGFs, intravitreal, whichever intravitreal injection. And maybe we'll see how it goes. We hope we don't lose any eyes at that particular point. Gachago, anything?
Yep, that's it. I concur.
Carlo?
One last question before we close this session. Is there any role of topical quinolones post-intravitreal injection?
We've had that discussion over and over. I remember in many retina meetings. I can put my hand up and say I'm one of the people who uses quinolones post-intravitreal injection for 2 to 3 days. Maybe I sleep better, I don't know, but there's always that. We've discussed it. The patients who take it for a day, the guys who do 3 days. I don't know. There's no hard line. Fine, boosting resistance in bugs around the eye and all. But I'm someone who, it's not based on science, I must confess, but I've never had a case of endophthalmitis. Maybe it's because of that, I don't know. Gachago?
Yeah. Well, I mean, for a while, we only used to, places where I previously was, I mean, we'd only give the povidone before and after. And that cleans out your conjunctival sac and of course your eyelashes, which are your biggest sites of contamination. And it was given quite safely. But as you're saying, many places we still give an antibiotic post-injection. When I give them, the time I give antibiotic without fail is when I do bilateral injections. When I do bilateral injections, I will cover you with a quinolone for 5 days, both eyes, because it's a high risk activity even for me. So if I have to give you bilateral injections, I will definitely cover you with a fluoroquinolone for 5 days, just to avoid that risk. Or if I give Osidex, because Osidex has a huge bore. It's a 21 gauge needle, it's huge, and the track is significantly large. And because of that, I'll always cover with antibiotics. So in those 2 cases, I will always do that. The rest, the jury's out. Usually we do it to sleep better at night, but as you're saying, it's not scientifically proven that giving antibiotics after standard intravitreal injections with your 30 gauge needle will lead to any reduction in the rates of endophthalmitis.
Yeah, actually, any antibiotic, be it a quinolone, be it immunosuppressant or whatever it is. I think there was something by Novartis. Kalu, you introduced the Novartis people.
Yeah. The Novartis had a 5-minute presentation. Since they are our sponsors today, I think we can give them the floor. Yes.
Okay, thank you. Allow me just to share my screen. Kindly confirm that you can be able to see my screen.
Yes, we can see your screen.
Okay, thank
Yes,
you
you
so
can
much.
see the screen. Yeah.
Okay, let me just put on the video first. So I'm Brian Barani from Novartis, and thank you, Dr. Gachago and Dr. Onyango and Kalu for the great insights. So I'll just take you through first in terms of Patiza, specifically in terms of the efficacy and the safety profile of it. And I'll quickly just highlight one of the key studies, and this is the Marina study. And the Marina study, it was a study that was just done to evaluate the efficacy and safety of ranibizumab injection in prevention of vision loss. And in terms of the design, it was a 2-year study. It was multi-center, double-blind and sham-controlled study. And we had 716 patients who were enrolled with minimally classic or occult with no classic lesions secondary to AMD. And out of the 716 patients, we had 238 of them that were randomized to receive the sham injections, and also 238 to receive ranibizumab, that's 0.3. And also 240 were randomized to receive the ranibizumab 0.5. And when you quickly go through the results, you can clearly see that the percentage of patients who are able to lose less than 15 letters from baseline after month 12 were 52.9 in the sham group and 92 and 90 in the ranibizumab arms. Check on the best corrected visual acuity after the 2 years. You can clearly see with the sham group, we had a decrease in visual acuity at negative 14.9, while with the ranibizumab arms, we had gains, that's at 5.4 and 6.6 in both arms. Also, when you look at the patients who are able to gain more than 15 letters after the 2 years, you can clearly see that in the sham group, we had 3.8% of it, and in the ranibizumab arms, we had 26.1 and 33.1. So when you check also on the mean change in visual acuity over the 2-year period, you can clearly see from the graph with the ranibizumab arm, there was increase in terms of the gains, that's 5.9 to 7.2. Look at the sham group 2, there was decrease from 3.7 from month 0 to 10.4 decrease. Overall, when you compare with the sham and the ranibizumab arms, the improvement in letter was 21.5. I know that's something you can really appreciate from your space. So conclusively, you can clearly see that there were benefits in VA in both the ranibizumab arms, and those benefits, they were sustained over the 2-year period. And when you also talk about the incidences of the ocular adverse events, there were low rates of the ocular serious adverse events within the ranibizumab arms. I'd also just like to share with you one of the alerts, and this is an alert that it was published. It happened in Mauritius. And in this alert, we had some 4 patients who were able to go blind. These patients were on bevacizumab, and majorly it was on the compounding errors that happened when administration of bevacizumab. It happened in Mauritius. Someone can ask, Mauritius is very far from here. Our close door neighbors here, that is Sudan. At Maka Hospital, we had 34 patients who went blind after being given bevacizumab. I know these are devastating conditions that we really hope that we really won't find ourselves with, and also the patient specifically too. So someone will ask, so why should I give Patiza, or why is Patiza better in that space? This because with PATISA, there exists extensive, well-characterized educational materials in terms of the safety profiles, and this is from the randomized clinical trials, the marketing studies, and also there is an elaborate way in terms of reporting all the advanced events as compared to the off-label drugs where first, in terms of the materials, just to assist the healthcare providers as a guide to understand in terms of usage of a product, that's something that is not really available. Also, but with PATISA, you are able to achieve lower systemic exposure among the other anti-VEGFs, meaning this is majorly due to the fact that PATISA is designed for the eye and made for the eye. So there is minimum systemic exposure. With PATISA also, PATISA has an ocular half-life of 9 days and a systemic half-life of 2 hours. So that means it's able to stay longer in the eye and stay less within the systemic. So with that, then there is limited side effects to our patients. And also, when you also try to evaluate in terms of exposure systemically, there is a 0.1 less 0.1% decrease in terms of exposure. And we all know that these VEGFs are also very important in terms of angiogenesis. When you have a disruption with the VEGF within the systemic cell, then there is usually exposure also to myocardial infarction, stroke, renal dysfunction, hypertension, and also some wound complications. So this is just a dramatic expression just to briefly highlight what I've really shared with you, that PATISA is indicated for the eye. That's why you can see it's used in ophthalmology. When you come to also the structure itself, PATISA is a monoclonal fragment. It doesn't have the FC portion. So what does that mean? That means that there is better safety profile since there is easy travel between the barriers itself. Then also when you see about the half-lives, which I've also talked about, there is less exposure systemically in terms of effects. This is just information that it's in one of the studies. This is from the V1 and V2. You can clearly see that with PATISA, for patients majorly above 85 years of age, when you look at the cerebrovascular events and also the cardiovascular events, the percentage was 3.4% for the cerebrovascular events and 10% in the cardiovascular events. So it really just shows that in terms of safety, then PATISA itself has a better safety profile. So a quick summary: PATISA is just our new brand of ranibizumab, and it's from the same manufacturer as Lucentis. That means that with PATISA, it meets the highest manufacturer standards. And PATISA offers the same benefits and confidence as Lucentis. And with PATISA, you are able to get the unsurpassed efficacy, durability, and also the safety profile. And we usually say with PATISA, you are able to get the same great efficacy and safety that you know at a more accessible price. Thank you, and kindly prescribe PATISA. Thank you.
If you may, if I may ask, well, Movan, it's a question and a comment to Brian. Thanks for that. We use PATISA regularly for DME, CRVO, ROP, etc. Now we quote figures from elsewhere. Why can't you guys sponsor a simple study like use of PATISA in CRVO, for example, for the next 6 months? Novartis is sponsoring something. I don't know. All CRVO cases for the next 6 months are sponsored by Novartis for a study. We see what outcomes we'll have if they're different from the outcomes you see out there. Something as simple as that, rather than I say this every year, I think. Probably, I know I answer some of your guys in your company have heard me say this before. But we'd like to put our own figures rather than Caucasian figures, because you know the pigment in the eyes and all, probably are prone to more inflammation, things like that. It would be good to know what our eyes look like rather than quoting other things. I don't know, what do you have to say to that, Brian? You know, the black, like the studies that have blacks in Jamaica and Pennsylvania and in Minnesota are very different from the ones in Africa.
Thank you, Daktari, for the great question. So in response, I don't know whether Dr. Martin is on the line. I think it's more medical. These are areas I think we are also working towards to see how we can really partner in terms of just working out to ensure that we are able to also partner to ensure that we are also upskilling and also working to also sponsor some of the studies locally. So I really leave medical to respond to that. I don't know whether Dr. Martin is on the line.
Yes, Brian, I'm on the line, and thank you, Dr. Oscar, for the question. What we've mainly found in times when we've wanted to carry out studies, I know we've discussed this with Dr. Kibata at some point, but the kind of reviews that we would have on institutions prior to particularly interventional studies being carried out have been the main inhibiting factor when it comes to carrying out some of these studies locally. We have had surveys done and just looking at the capabilities of some of particularly the facilities we have and going through what would be required in terms of drug storage facilities, the supply chain, and a lot of issues, particularly surrounding availing of the drugs, which have previously been a problem, but a lot of improvement has been done in that space. So looking forward, we are going to see some trials actually coming from South Africa, where most of these studies have been done, particularly when looking at blacks, to include a few centers within the East African region.
Thank you.
Brian? Dr. Mbongo, your hand is raised.
Yes.
Dr. Mbongo?
Yes. I wanted to emphasize on the comment of Dr. Onyango about study, and also to comment on the issue regarding use of Avastin, to carry Avastin, to prepare Avastin, to keep it in the bottles. A study will also be important in that direction, because what we don't talk enough about it is long-term mortality related to the use of anti-VEGF, and particularly bevacizumab, Avastin. Several studies have shown a high percentage of mortality related to use of anti-VEGF. For us, we just inject. We have never done a study for the follow-up of those patients in terms of mortality, so it will be important that even a sponsor of study in that direction, so that we are able to see in our setup really what is happening with use of anti-VEGF and particularly Avastin. Because as long as we don't have data, people will not understand that there is a risk related to use of bevacizumab, Avastin. It's not only in terms of infections, as it was mentioned, but it's also in terms of mortality that the rate is higher. So if you add in our setup the fact that we don't use one vial, we prepare and we keep it for 2-3 weeks, and adding the suggestion of carrying it from a town to another one, that increases the risk. And I found that it is only a study that will be able to convince people so that we are serious, we are aware about the risks that patients are submitted to when we use Avastin. Thank you.
Thank you, Dr. Mbongo. Thank you, Brian, for that short, precise presentation. And thank you, Dr. Gachago, for the wonderful presentation that we've had. It is always a pleasure learning more and more. And even when some things are repeated, they get to stick even better. So I hope our practices in intravitreal injections will improve, which will ensure that patients get the best from us as their doctors. To remind people that for your CPD points, kindly send your name and the name of your institution to the OSK number or email if you do not have the number. Also, so that we can be able to get those done in the next week. Otherwise, thank you all for attending, and we will keep in touch and give you the schedule for the next meeting we will be having. Thank you and have a good evening.